I'm going to talk quickly about PCSK9 inhibitors and their role in management of lipid problems. We've all seen these guidelines again and again where we need to give very high doses of drugs in order to bring the LDL cholesterol down. Now, as you know, the goals which are most recent are reduction of LDL cholesterol by 50% and an LDL cholesterol below 55 milligrams for these high-risk patients. Now, in order to achieve that, statins often are not sufficient. We also heard that statins and ezetimibe can be used. And as you can see, we are now moving more and more towards lower goals of less than 40. And as you know, the Lipid Association guidelines actually went down to 35 for these extreme high-risk patients. And clearly, you heard so much about ezetimibe, but in spite of giving statins full dose and ezetimibe, sometimes the LDL cholesterol cannot be brought down. We also know that there's always a residual risk after giving statins and ezetimibe, and therefore the PCSK9 became available. Now, of course, you have PCSK9 mutations in people, and they have very low PCSK9 levels at birth. They have low LDL levels, and it translates to a significantly lower cardiovascular risk. So from natural genetic studies, we know that if you have less PCSK9, you get less coronary artery disease. You all know the functioning of the PCSK9. As you know, the LDL receptor catches the LDL particle, it absorbs it into the hepatocyte and then destroys the LDL particle. And then the LDL receptor comes out again onto the surface to catch more LDL particles. PCSK9 is available in the body. It sort of acts as a counterbalance. And when PCSK9 combines with this complex of LDL plus receptor, it tends to destroy the receptor itself and therefore reduces the LDL receptors. So when you inhibit the PCSK9 in the blood, you allow these receptors to resurface again and catch more LDL. Another issue that we must remember is that when we give statins, it upregulates the PCSK9. So statins, though it reduces LDL, because it increases the PCSK9 levels, they need to be blocked. And blocking the PCSK9 will therefore increase the LDL receptors again and reduce the LDL cholesterol. So that is why when you give statins, you have to keep this in mind, and that is why PCSK is so important. Now, Evoluquemab is one of the first PCSK9 which was studied, and as you can see from here, the blue dots, when you give Evoluquemab, there's a rapid rise in the blood levels of Evoluquemab. Along with that, if you look at the green, there's a rapid fall in the PCSK. And if you look at the red, which is the LDL, again, a very dramatic fall. And this happens very quickly in a matter of a few days to a week. So dramatic reductions of LDL cholesterol when you give PCSK9 inhibitors. And as you can see from here that when you give ezetimibe to full dose statins, you get about 15 to 20% reduction of LDL. And often that's not sufficient to reach the goals of 40 and to have 50% reduction, especially in those who got very high LDL cholesterols. And you can see the dramatic benefits of PCSK9 by producing almost a 55 to 60% reduction in your LDL cholesterol. The first trial that we saw with PCSK9 was the Fourier Trial. It was a huge trial, almost 30,000 patients with stable disease and established cardiovascular disease. And their LDLs were equal to or more than 70, so they were not extremely high LDL values. And you can see placebo versus Evoluquemab. And it was clearly beneficial. If you look at the endpoint, the primary endpoint, it was significantly different. If you look at the sub-study with different characteristics, if you can see people with myocardial infarction more than 2 years ago or myocardial infarction less than 2 years ago, both had benefits. If you look at patients with more than 2 prior MIs compared with 1 prior MI, both had benefits. And if you look at multivessel disease versus no multivessel disease, again benefit. So what you saw from these previous 3 slides is that if you had myocardial infarction, which was recent, if you have multivessel disease, and if you have more myocardial infarction, that means you fell into the higher risk category, then of course the benefit of PCSK9 would be more because the reduction of LDL would be more and the reduction of LDL below would benefit. The other big benefit of PCSK9 is reduces ApoB, and very important, as we know, Indians have a lot of high LPA, which is bad for atherogenesis, and this is the one drug that you have which reduces LPA, which statins do not do. So I think even in patients with normal LDL cholesterol, use of Evoluquemab can at least reduce the LPA in these patients who have very high LPAs and thereby reduce their proatherogenic parameters. LDL reduction with Evoluquemab is present both in diabetic patients as without diabetes. So clearly that is not an issue. Now, if you look at some of the intravascular data, you can see that as you reduce your LDL cholesterol down with PCSK9 and you come down to values of 30 and 20, you see that there's significant reduction of atheroma volume. So clearly, if you want to reduce atheroma, as the patient asks us, can you take my blocks away? Well, this is an answer. Yes, you can reduce atheroma by bringing LDL. So you keep your LDL down at about 80, you're not going to reduce your LDL blocks, your cholesterol blocks. But as you bring it down to 30 and 40, you're going to see the benefit. And this benefit is seen at every level. So if you look at the table on the left-hand side, LDL cholesterol 70 to 99, 3% reduction. If you go to 20 to 49, 50%. If you bring your LDL below 20, again, significant benefit. So clearly at each level of LDL reduction, you get increasing benefit. And I think that needs to be kept in mind, especially when we are talking of very complex plasty patients, patients with very high LDL levels, patients who fall at the very high risk or extreme high risk. That means young people with multiple procedures. And these patients we see all the time. In our clinics, we see patients who had PTCA done, then again PTCA, bypass surgery, still having some ACS. So these are the patients where you really, really need to be sure that you bring their cholesterol down to way below levels. Now, of course, the question is safety. Many people worry that bringing LDL cholesterol down too much is going to produce harm. But I think this is a beautiful chart. 100 above LDL above 100, which is in red, going all the way down to LDL below 20 in purple. And you can look at neurocognitive, which is worry. You look at the liver, you look at the muscles, you look at the non-cardiovascular death and hemorrhagic stroke. These are the anxieties which we have of very low LDL cholesterol levels. And you look at the lovely colors out here, whether it's purple, green, or red, there's hardly any difference either in neurocognitive, liver, muscle, non-cardiovascular death, and even hemorrhagic strokes. So really bringing LDL down to this level is fairly safe. So there is a safety factor which has been seen. And again, people say that brain requires the cholesterol, etc. Cells require cholesterol, but this is not true. Each cell has an inherent capacity of forming its own LDL. The blood LDL has got no relationship to brain management. LDL, in fact, does not cross the blood-brain barrier. So there's no question of serum LDL value, if it's low or high, affecting metabolism in the brain. Now, again, we look at low LDLs in genetic background. And if you see these people with PCSK9 problems, and you can see they're born with LDL of 14 on one side, you can see the other patient with 15, and they managed very well. They had children, they were absolutely normal. So clearly, even having LDL levels as low as 14 or 15 right from birth is not really an issue. The second trial was the Odyssey trial, a different drug, Evoluquemab, again PCSK9 inhibitor. These were patients with acute coronary syndromes, again very large study, almost 20,000 patients. And you can see again the similar drop of about 60% in your LDL cholesterol compared to placebo. Is not placebo, placebo is standard statin therapy. And then you can see again primary efficacy, MACE, which is cardiovascular death, MI, ischemic stroke, etc. Again, you can see a very significant, look at the p-value, 0.003. So significant benefit of primary endpoint by reducing their LDL cholesterol down. And not only that, they found even an all-cause death reduction of a significant amount. So clearly reducing your LDLs with the use of PCSK9 has been dramatically beneficial. Now, which patients do you think would require this? Well, one, patients with multivessel disease. Clearly more disease, more infarcts, more ACS, more benefit. Recurrent problems, recurrent myocardial infarction, recurrent stenting, bypass plus stenting. Again, after that, another ACS, very important. Young patients, very, very important in our country. The 40 years old with so much disease in their coronary arteries, one stent followed by another after a few years, another problem, recurrent problems in young patients. Patients with multivascular disease, so polyvascular. They have a myocardial infarction, they also have a stroke, they also have peripheral vascular disease. So patients with polyvascular disease affecting multiple vascular organ problems clearly is another indication. People with ApoB, which is very high, patients with LPA, which is very high, disproportionately high, in spite of LDLs not being high, are very important. And of course, I'm not talking about familial hypercholesterolemia, but there is actually life-saving. There is no question about it that in familial hypercholesterolemia, this is a life-saving drug. The most recent trial was the Evopax trial, which was looking at Evoluquemab in the acute coronary syndromes to see whether we could target this LDL early. So rather than waiting and giving statins and then ezetimibe and then stepwise over weeks and months, can we give them PCSK9 at the time of their admission for ACS? And you can see here again dramatic reductions of LDL, and clearly they did not have this was not a long-term study, but it was a safety study. It showed two things: that you can give PCSK9 in the hospital post ACS, you get the same dramatic reduction of your LDL cholesterol, and it's very safe to do so. So nowadays we have tended to do that. Patients who come with these multiple problems and ACS, we give them a PCSK9 inhibitor before they leave the hospital. The big advantage is that they get used to taking the injection, they know it is safe, and is much more likely that they will continue to take the PCSK afterwards. I know PCSK9 is expensive. I know it is an injectable, but I mean, if a diabetic needs insulin, you give him daily once, twice a day insulin injections, patient has to take it. And similarly, the patient needs twice a month, then clearly that's not such a big problem. Cost is an issue, but just think of the patient coming back again, requiring another myocardial infarction, stenting, or bypass surgery. Think of the cost and look at the cost in its totality and the dramatic benefits that you get of reducing LDL. I think there is no doubt. We also know that the earlier you reduce the LDL, the better. This is more so in patients with familiar hypercholesterolemia. But unfortunately, I see patients today who are 40 years old.
Sir, 1 minute.
Whose LDLs are high, and we need to treat them very early. So I think it's important we remember concept 1, LDL exposure time, concept 2, aggressive treatment, and concept 3, combination therapy. Thank you very much indeed.